Welcome to the University of Pittsburgh Health and Explainable AI podcast, a collaborative initiative between the Health and Explainable AI HexAI Research Laboratory and the Department of Health Information Management at the School of Health and Rehabilitation Sciences, and the Computational Pathology and AI Center of Excellence, CPACE, at the University of Pittsburgh School of Medicine. I'm your host, Jordan Goss-Poire, a health and science reporter. In this podcast series, we explore the transformative integration of responsible and explainable artificial intelligence into health informatics, clinical decision-making, and computational medicine. From reshaping diagnostic accuracy to enhancing patient care pathways, we'll highlight how AI is creating new bridges between researchers, clinicians, and healthcare innovators. Led by Ahmad P. Tafti, Houman Rashidi, and Liron Pantanowitz, the HexAI podcast is committed to democratizing knowledge around ethical, explainable, and clinically relevant AI. Through insightful conversations with domain experts, AI practitioners, and students, we'll spotlight the latest breakthroughs, discuss real-world applications, and unpack the challenges and opportunities that lie ahead in responsible AI in healthcare. So, whether you're a student, practitioner, researcher, or policymaker, this is your gateway to the future of AI-powered healthcare. Today, on this podcast episode, we're going to speak with Dr. Bradley Erickson, a professor of radiology and director of the Mayo AI Lab. We're going to focus on the application of AI in radiology and imaging, and we're going to frame our discussion for high school students who will be participating in an AI summer school in medical imaging informatics this month, hosted by the University of Pittsburgh's Computational Pathology and AI Center of Excellence and Pitt's Health and Explainable AI Research Laboratory. Welcome, Dr. Erickson. Thank you so much for joining us. Would you like to introduce yourself?
Yeah, so I'm Brad Erickson. I'm a neuroradiologist at Mayo Clinic. I've been on staff here for 32 years and did my MD and PhD degrees here as well. So I've been here well over 40 years. So I do that about half of my time. The other half of my time, I run the Mayo AI Lab. I've got a number of postdocs, and at times, particularly during the summer, I have college students and even have had a few high school students work on AI projects. So AI is a wonderful field because in many respects, you can get into it with relatively little background as long as you have people around you who can fill in the gaps. And so I've really enjoyed it. I did a tally for a grant recently, and I've had 83 people that I've had in my lab. So it's a pretty large group now, and I love to see that. They're almost like a family to me.
So, out of curiosity, with AI advancing so fast, how do you approach deciding what your fellows should work on at your lab?
So a major factor is grant funding, right? We're always working on grants and project ideas, and if there's funding to do a specific project, that's probably 3/4 or more of the projects are driven by grants and funding for the fellows. And then I have a little bit of more discretionary money where if I see an interesting idea that was published, or one big advantage I have is being an active clinician. I brush elbows with people who often say, "Hey, what do you think about?" And then the idea they have, and some very interesting ideas come out of that. And so some of the projects are more of that opportunistic, let's take a swing at that and see whether it can work. So it's a mixture, but grant funding is kind of the core of the projects that we do.
I mentioned Pitt's AI Summer School in Medical Image Informatics. Maybe there's a way some of our students could be of use to your fellows and give you even more work to coordinate at your lab. Getting back to our interview, we would like to give high school students an opportunity to imagine themselves attending a conference on AI and radiology, and we'd like to give them a feel for some of the types of technical questions that experts might be asked. So we'd like to start off by asking you 4 of our own technical questions. Here's our first one. People sometimes assume radiology AI is just another computer vision problem. From your perspective, what are the biggest differences between training AI on medical images versus everyday images, both technically and clinically?
There are a couple of fundamental differences. One is that there are actually many types of radiological images, right? So We often see radiograph images, so like a chest X-ray or a bone X-ray of a fracture. That's somewhat similar to what we see with a photograph in that it's black and white instead of RGB, but otherwise relatively similar. But once you get into CT scans or MRI scans, you start to get much more significant differences. And that's because you have a stack of slices that have spatial relationships to each other that you really don't have with photography. You kind of have something like that when you go from camera to video, right? Now you have a 3D stack, except it's time rather than space that is that third dimension. And actually, in some medical images, we do have a third dimension time, like ultrasound images can be acquired as a 2D slice, but you can capture, for instance, the heart beating. And we can actually do four-dimensional CT and MR images where it's three spatial dimensions and a fourth time dimension as well. So we have the ability to capture more information that way. The other thing is that there can be specific meaning to the pixel intensity. So for instance, the guy who invented CT was Sir Gottfried Hounsfield. Hounsfield units are the actual meaning of intensity. So in a CT scan, minus 1,000 is the density of air and 0 is the density of water. And so tissues have reproducible intensities where, bone tissue is up in the thousands, and blood, for instance, if it's an acute hematoma, it might be 80 to 100. And as it becomes more clot, it becomes a little denser. And then as the clot goes away, it becomes less dense. And, there are specific patterns like that. So that's one fundamental difference. The other thing is that early on, the perception is that what we do in radiology is we look at image, kind of like people look at a picture of a cat and say, that's a cat. But there's a lot more to it in radiology, in that if I look at a brain MRI and I see hyperintensities on T2 weighted images, if it's a 30-something-year-old female with numbness and tingling, that's multiple sclerosis. If it's a 70-year-old guy with stroke-like symptoms and hypertension, those are hypertensive strokes. If it's somebody with known metastases elsewhere, it's probably metastases. And so the non-pixel information is very important to making the right interpretation of what's going on in the image. And so that's another fundamental difference between photographic images and medical image and medical image interpretation.
You mentioned imaging dimensions, like spatial dimensions, and new dimensions, like time dimensions. What other dimensional categories exist, or could exist, that we should add to our list to study?
For instance, with MRI, we can acquire images with different tissue properties. So I mentioned a T2 weighted image, which essentially is how fast the protons get out of phase. We also acquire T1 weighted images, which is how fast they come back in alignment. We can add IV contrast. We can measure diffusion. We can measure perfusion. There are all sorts of things that we can measure with MRI. But since they're all in the same spatial matrix, we can have a 5, 6, 7-dimensional image where you have the T1 property and the T2 property, just like you have the time or XYZ component. So yes, we do have 7 and 8-dimensional images that we sometimes work with.
In general computer vision, models can often highlight objects like cats, cars, or faces, but in radiology, the stakes are much higher. What does true explainability actually mean in medical imaging AI? And why are heat maps or saliency maps often not enough for clinical trust?
Yeah, that's a critical, often misunderstanding, is that they show you the heat map, the saliency map that says, look, the lung is lighting up or the heart is lighting up. Don't you understand it? And of course, the challenge is that oftentimes in medical imaging, it's not finding where it is, it's finding what it is. So for instance, I do neuroradiology. I can build an AI for looking at brain tumors. But it's real easy to see where the brain tumor is, just like it's easy to see where the cat is. But saying why that tumor is progressing or why is it IDH mutant or wild type. Saliency maps don't tell you why, it only shows you where. And so that's a critical thing. And particularly as deep learning models started to predict these things, probably based on the texture. And we humans don't have a good vocabulary for texture. For instance, if you talk about the corduroy pants or that you wear, is that a number 3 texture or is it a 5.6 texture, right? We don't have language for textures. And if you don't have language, it's really hard to explain something. So that's why I think we are really falling way short on true explainability in AI.
In consumer AI, labels are often relatively straightforward. But in radiology, even domain experts can disagree on findings or diagnoses. How does uncertainty in medical ground truth affect model development, validation, and deployment?
Yeah, that's a huge problem because in many areas of medicine, getting the truth can be difficult. I mentioned that I work on brain tumors and that we want to try to predict whether a tumor is progressing or regressing. And it turns out that some of the new therapies for one type of tumor called a glioblastoma, early on, something about the reaction of the brain as it's probably killing the tumor actually looks like progression. And by that, I mean it enhances with contrast a lot. It looks angry. It looks like it's growing. There's mass effect, all that sort of stuff that we associate with tumors actually can be a positive response. And so being able to differentiate those is critical. But how do you tell the difference? Because it may be that the tumor early on is responding and later it's starting to progress again. For some odd reason, people don't like having their brains biopsied, right? It's nasty to have to do that. So how do you get truth? And it's very hard. Ultimately, what we do in most cases is we just look over the longitudinal patient record and say, well, they ultimately passed away on this date. They must have had progression. And let's guess it started about here. But that's a really hard problem in many areas because the truth is not always known. We just have to guess what it is and hope that we're guessing accurately enough to be able to train a model. And sometimes it's the outliers that are the interesting ones that help to inform us about, yeah, we thought that this was a case of progression, but when we looked at it closer, we saw that that wasn't the case. And so that's where this uncertainty of labels and training a model is a big challenge. And uncertainty is a reality in medicine, right? It's rare to go to the doctor and he looks at you and, yeah, I don't need to examine you. I can tell you, you've got cancer, you're going to live for 4 months. If you see a doctor like that, you should probably go find another doctor, right? That's just not the way medicine works. And yet that's the way today's AI tools work, right? You give it some piece of information, a CT scan, and it says lung cancer, right? And I think that's another critical element that's closely aligned with explainability is uncertainty. And, if there's a high confidence, then you really want to understand how did they come to that conclusion. If there's low confidence, you probably just want to move on and look at something else.
There is a lot of discussion about whether AI will replace radiologists. But in practice, the harder problem may be workflow integration. What are the biggest challenges in designing AI systems that radiologists actually want to use and trust in real clinical environments?
Yeah, so I think you hit on it at the end there when you said trust, right? If you can't trust what the AI is telling you, you're never going to be comfortable using it. And so to some degree, you want to start with components of the workflow problem that are verifiable so that you can say, oh yeah, the AI got that right. It got that right. And so probably the part that I would say we should start on are things like text summarization. So I mentioned before that an important part of making an interpretation is not just the pixels, but it's the other information around it, the fact that it's a 30-year-old female or whatever. which we can look up in the record and say, oh yeah, AI got it right. And, going a little bit more in depth, if you look at the clinical history and have AI summarize that for you, the fact that they had a certain surgery, the fact that they had a certain type of cancer in the past that was treated a certain way, all of that is verifiable. And in the past, I had to go back through the medical record to find all that to help me make the right interpretation of the images. If AI can do that, and increasingly we're seeing tools that can do that for us, that helps us to gain confidence that the AI does the right thing. And as we just kind of do that stepwise, okay, it's getting the text right. And then as you start to see, oh yeah, it's starting to make predictions that are sensible. And I think another component of that is uncertainty, right? If it makes a prediction with high confidence, and then you go back and look at those and it gets most of those right, that's a good thing. And if it says, yeah, I have low confidence in my prediction here, it might be X, but it could be Y, we're willing to pass those off. It's the high confidence errors that it makes. And today, there is no confidence component to predictions that is communicated in almost every case. And so everything is binary. You have this or you don't. And the fact that at least some of those are going to be low confidence, even if not communicated to you, that's a problem. And so I think that that's another component of acceptance, is that we need to get a sense of the confidence in a prediction and be able to ferret out the high and low confidence predictions.
For our next questions, we'd like to change vantage points and give students an opportunity to imagine themselves working in hospitals as administrators and asking their resident AI expert, how is AI being used in my hospital? Can you tell our high school-aged administrators how AI is being used at the Mayo Clinic to help them visualize some main use cases?
So the most common area or department that has AI is radiology. If you look at FDA clearances, I think about 3/4 of the FDA cleared tools are in radiology, and probably 90% if you include all the imaging related ones, like cardiology does a lot of imaging and whatnot, pathology. And so those are the areas where you will see it used fairly frequently. And the challenge is that the models or tools that we have today don't produce interpretations of images. They are narrowly focused, like, does this patient have an intracranial hemorrhage? Do they have a pulmonary nodule or embolism, right? So they do a very narrow task, an important one, but still a tiny fraction of what I do as a radiologist. And so from a payback perspective, which is often what the administrators are concerned about, the payback is not entirely clear. Now, the hope is that over time, as we get better and better tools that will do a wider swath of what the task is, that, the payback will become more clear. But, the administrators ultimately are responsible for keeping the hospital financially afloat. They say no money, no mission. And if you can't pay the doctors and cover the hospital bills, you aren't going to have a hospital. So, they're responsible for figuring out that ROI. And it's a little bit of, you have to take a risk on AI to see where it makes sense to deploy, and then you put your money there. And I think that's kind of what the administrators are still figuring out. And probably the biggest payback is around these text type of tasks of summarizing medical records so that I can quickly see the thumbnail sketch of what is this patient about. It's also frequently used during patient encounters. It used to be that the doctor would talk to you, and then afterwards they would go and scribble down or dictate or something, record what was actually happening. They now have ambient recording systems that actually record that whole conversation. It recognizes when you're kind of shooting the breeze, the niceties, just to get to know the patient, versus the actual content of the medical discussion. And so it's probably faster for the doctor, and it's probably also more comprehensive, because oftentimes the appointments are stacked up and they don't do that recording of the note until end of the day or the next day. So I think there are tools like that that have clear payback, much more than the sexier, oh, we're going to replace radiologist or whatever. I think AI is also going to have a big role in chronic disease management, things like diabetes and hypertension, where a lot of it is just encouraging patients, hey, you got to stick on this. Hey, your blood glucose was high. What did you do or not do? And AI is, I think, much better at kind of cajoling patients in the way that's personalized to them, as opposed to a doctor meeting with them once every 3 months and saying, gee, your weight is up and high blood pressure is up. Don't eat so many donuts. Probably not as effective as some sort of a coach that sits on your wrist or sits on your phone and, reminds you as you're looking at the lineup of donuts that, hey, here's one that's a little bit more glucose friendly or hypertension friendly.
For students who might like to consider pursuing careers working in healthcare settings, in supportive roles, other than as doctors, nurses, or researchers, what are some things that hospitals ought to be addressing connected with AI that students can get involved in? Like AI governance and project management, for example?
I do think that issue of governance and monitoring AI performance is something that people are tumbling to, but really needs to be a first or maybe worst case second step. Of course, that's not how technology develops. And, oftentimes technology does get out in front of things like governance and all that. We scientists don't like to be governed. We like to discover. But, at some point, you have to become an adult in the room and start to put your head around it and say, okay, what circumstances are we going to deploy it? And more importantly, when do we stop deploying it? When do we pull it back because it's not performing the way we expected? And thinking about those things prospectively is really critical because you don't want to find out too late that you weren't monitoring and governing the deployment the way you should have been. And so I think it's that sort of thoughtful, prospective estimation of where you need to be that a lot of hospitals probably haven't addressed completely yet.
On this podcast, we like to close our interview by asking our guests to offer students a research project idea. In this case, what are some things that high school students could think about getting involved in helping with?
So, the biggest challenge with getting high school students or anybody involved is data access, right? So if you're not an official appointee into a hospital, getting data access is a challenge. Having said that, I believe that this whole chronic disease management piece is a big thing, and that doesn't necessarily involve a medical device. So I'm a big believer that, things like watches and wearables that monitor activity are a critical element of helping with chronic disease. I think that measuring heart rate variability, we know is a big predictor of health. There are indicators that you can even start to detect things like stroke and other problems before a fall because they're not moving quite the same way. Their cadence isn't quite as fast as it used to be because they're not as sure as their step. That sort of data, I think, is much more accessible. And I think, figuring out how do we collect it in a privacy respecting way, but also what do the notifications look like? And at what point do you actually tell the patient, hey, you better start thinking about this? I think those are the pieces that a high school student could definitely get involved with, is because they deal with their parents and their grandparents who are likely the targets for that. And, what's acceptable and what isn't acceptable. I think it's that pervasive data that's probably the more feasible thing for high school students to get involved with.
We talked about Pitt's AI summer school program, but we know that your team has developed some resources for young people too. Can you tell us about these?
Yeah, so we have built a website that consists of a number of Python notebooks, and specifically they all run in Google Colab. So that provides free access to GPUs. So if you're interested, it's called midel.org. And it has a number of different topics. It starts from fairly simple, here's how you prepare data, here's what a neural network is, on down through, fairly cutting edge AI topics. And so if people are interested in actually running their own model, we have a few simple data sets out there that you can download and run. and you can change the code. We stole a technique from one of the other educators in more general AI, where he uses these Colab notebooks with code and then explanation of what the code is doing, so that then students can try saying, gee, I wonder what happens if we change this or change that. And that, I think that hands-on experience is how you really learn not just the simplicities of programming, but actually the concepts of how AI works and how it can fail.
Ironically, it seems like the resources that you've developed for high school students would be of great use for adults too, and also hospital staff, to use to become more technically proficient in developing AI applications. All right, back to closing out our interview. One other thing that we like to do on this podcast is to offer our guests an opportunity to make a pitch to students to join their labs. What's your pitch to new student recruits?
Well, I guess I didn't tell you. Actually, in a month, I'm retiring. So I'm actually not looking to recruit any students now. There is a person who's going to start to follow on in my lab. I would instead give a shout out to the students that I've had in the past. They talk about, you stand on the shoulders of giants before you. This is kind of that reverse thing, that I'm standing on their shoulders. But it's been wonderful. I've had some fantastic students who have gone on to be very successful. Some of them have done their own startups. Some of them are working at Google and OpenAI. A couple of them are even at Y Combinator right now. So it's been really wonderful to have all those students. And, that's what kind of, I hope, tries to keep me at least a little bit young. So, I'd encourage the students to try to find a mentor, and, the right person can really make their career go fast. So be picky about who you work with, but also be understanding that, they may not have done a lot of mentoring. So, working with them to help learn stuff is critical to success too.
Out of curiosity, what is your advice to your replacement on running your lab and being of use to Mayo amidst everything that is changing?
Yeah. So, I go around, and Ivana is her name, and, she goes around with me and has been for the last 3 months or so since she started. And I think, first of all, making sure that the people can ask any question. And part of it, when I start working with them, my background is that I did debate and speech in high school. And part of debate is that you often argue for sides you don't necessarily believe in, but that doesn't matter. And if I feel like we're becoming too rote, I'll often say things that I don't believe in just to see if they're awake. And I want them to push back on me. And if they feel like, oh, Professor Erickson here, I'm down here, that's not going to work. And so I want them to feel that they can push back on anything I say, that they should be able to question anything I say. And I think that sort of open communications is critical to really advancing education and advancing science. And so that's probably the most important thing. And then the second thing is that I think my role is, as much as anything, getting them resources and then getting out of the way with only occasional redirections or, hey, did you think about this or something? But if they don't feel like they own the project, then they don't really buy into it, and they don't put 110% into it. So, encourage people to not be too directive about, you need to do this and this and this and this. That might be necessary at the very start. And then conversely, for the students, is they need to take ownership, and that they should say, no, I really think this is how it should be done, and here's why. And, if they have a good argument, then a good mentor will listen to that. And even if they don't agree and don't believe, they ought to give a little bit of slack so that the person learns. I mean, if you never make a mistake, that means you've never learned, because you already knew it, right? So making mistakes is critical. And that's kind of the third thing that I often say, is that you need to give people just enough rope to not hang themselves, right? You need to let them make mistakes. Just don't let them make big mistakes, and, kind of guide them so that they learn, so that the next time when they are contemplating something that might be a mistake, they can fix it themselves.
That's really good advice for everyone running AI labs today or administering AI programs in healthcare settings. It's so important to nurture critical thinking and open communications around uses of AI, and then let people enjoy investing themselves into test projects where they can learn from the iterative process of trying things and making mistakes and making discoveries. For our high school-aged AI researchers and project managers, you've got your work cut out for you. Thank you so much, Dr. Erickson. It's been a pleasure speaking with you, and thanks for taking the time to join us on Pitt's Health and Explainable AI podcast. From the University of Pittsburgh, thanks everyone for tuning in and for following the series. Join us again on HexAI, where we explore the transformative integration of responsible and explainable artificial intelligence into health informatics, clinical decision-making, and computational medicine.